is here, and Dr. Gao Dongheng. And I'm Dr. Ning Guo from First Affiliate Hospital of Xi'an Jiaotong University. And I would like to say sorry and apologize for my another colleague, Dr. Zhu Yuan. He is an emergency case in hospital, so I will represent him to moderate this session. And it's great honor to have you to share the experience of beta blocker with Chinese colleagues tonight. And tonight, except you, and we also have another professor, Gao Dongfeng from Second Affiliate Hospital of Xi'an Jiaotong University. We are also good friends and colleagues. And Dr. Jiang Jun from Second Affiliate Hospital of Zhejiang University, and which located in Hangzhou. And another Dr. Yang Wenyi from Shanghai will join us for the discussion and the panel. So firstly, I would like to invite Professor Jules to give us a very important lecture about beta blocker. And Professor Jules, who is a very senior cardiologist in European and in Spain. And his main fields of interest are acute coronary syndrome and heart failure, cardiac toxicity of cancer therapies, secondary prevention, and stable angina. He was participated in numerous clinical research programs and has published over wow, 1,000 articles in medical journals, and has been a member different task forces for guidelines in acute coronary syndromes, heart failure, and angina. And also, he's a counselor of the European Society of Cardiology, chairman of the scientific board of the World Heart Federation, member of the European Association of Heart Failure, member of the EBAC and EBSC, and the General Secretary of the Spanish Society of Cardiology, and countries actively working in teaching and research programs with different international research organizations. So very welcome, and we have great honor to have you give us a lecture tonight. And I think you can start. Thank you.
Thank you. Thank you for the presentation and for the invitation to be with you tonight. And the topic is quite interesting because recently several large trials in secondary prevention with beta blockers challenged the role of beta blockers in the continuum of cardiovascular diseases. And that will be my discussion today. And I hope that we can share some interesting discussion at the end. And this will be the outline of my presentation. And let me start with the cardiovascular continuum. The concept of the cardiovascular disease continuum is represented here. It starts with risk factors, diabetics, hypercholesterolemia, hypertension, and so on. It provokes atherosclerosis, and just follow the line. And this is coronary stenosis. There may be a stroke, myocardial ischemia, coronary thrombosis, myocardial infarction, arrhythmias, sudden death, remodeling, left ventricular dilatation, heart failure, and the ultimate is the death of the patient. So there is somehow what is called the cardiovascular continuum, and in this cardiovascular continuum is dominated by catecholamines. And catecholamines play the activation of the sympathetic nervous system play a very important role in many and different physiological functions that are represented here. Yep.
I'm sorry.
I'm sorry. So I escape.
Yeah, we haven't seen the screen and the slides.
Yeah, okay. Share.
Yeah, share.
Yeah.
Okay, okay.
Okay. So, so go here. So this is the cardiovascular continuum. That is the outline of the presentation, starting for the cardiovascular continuum that goes from risk factors for ischemic heart disease through all the components of chronic ischemic heart disease with episodes of myocardial infarction, arrhythmias, heart failure, and is influenced by the sympathetic nervous system. And this plays a very important role in many physiopathological functions, including the control of heart rate, vasoconstriction of vasodilatation, coagulation activity, and so on, and is also imposing an increase in the cardiovascular risk because it promotes atheromatosis, atherosclerosis, plaque rupture, myocardial ischemia, thrombosis, arrhythmias and sudden death, and heart failure. So catecholamines are playing a yin-yang role. For one side, it plays a very important role in physiological functions, but on the other hand, an increase in the sympathetic tone increase the cardiovascular risk as is represented here. So in the cardiovascular continuum, we have something that may be useful in all the situations, that is the control of the sympathetic activation, and that is achieved with the use of beta blockers. And beta blockers, and in the old days, were considered the cornerstone for the treatment of cardiovascular diseases, and the use of beta blockers were class 1 recommendation in hypertension, acute myocardial infarction, and acute coronary syndromes, secondary prevention, chronic ischemia and angina, chronic heart failures, arrhythmias, and sudden death prevention. And that was 20 years ago, because there was an incredible lot of information supporting the idea that beta blockers were associated with an improving outcomes in all these conditions. And the problem is that, or the beauty is that we have gone through an extraordinary journey in acute coronary syndromes, as well as in chronic coronary syndromes that started some 50 years ago. And beta blockers at one time were the only thing we have for treatment of acute coronary syndromes with an impact on mortality. But since the 70s, there is a number of new strategies and new treatments that help to further decrease the mortality. That includes thrombolysis, aspirin, primary PCI, statins, better anticoagulation, association of antiaggregants, thin wall, hyperthermia, you name it. And the mortality rates in acute coronary syndromes fall from 30% 40 years ago to 5% nowadays, and that is including patients with that are admitted to the hospital after a sudden cardiac death or in cardiogenic shock. So the mortality in acute coronary syndromes has decreased drastically, but there is a number of things rather than beta blockers alone. And the same happened in secondary prevention in ischemic heart disease. Once upon a time, we only had beta blockers, but now we have ACE inhibitors, statins, antiaggregants, ICDs, revascularization, anticoagulants, and lipid-lowering agents, even colchicine, or a number of things that are still difficult to understand in the guidelines. And the mortality per year fall from 10% to less than 2% per year. That is very important, the cardiovascular mortality. But again, beta blockers are not alone. And the question is if in this clinical setting, when we have so many different things that we are using together, beta blockers are still playing a role, or are just a kind of drugs that can be discarded because have been outcome by new therapies. And that is the question, because the clinical scenario has changed dramatically. And the question is if beta blockers are still useful or not. So let me review some of the parts, the different parts of the cardiovascular continuum, starting with hypertension. And with hypertension, the latest guidelines, as an example, still recommend beta blockers as a preferred choice in a significant number of patients with hypertension. In fact, the latest European Society of Hypertension guidelines, instead of talking about the steps in selecting drugs for the treatment of hypertension, state that blood pressure lowering should be prioritized over the selection of a specific antihypertensive drug class, because the benefit originates from reducing blood pressure rather than using a particular drug. And they identify ACE inhibitors or RBs, beta blockers, calcium channel blockers, or diuretics as drugs that, through the time in different studies, have demonstrated that they not only control blood pressure, but also reduce some cardiovascular protection and reduce the number of cardiovascular events. And all these drugs fulfill the criteria to be considered compelling drugs to be used in hypertension. And the selection of these drugs should be based on compelling indication, contraindications, and comorbidities of our particular patients. You have to remember that is an old slide, but you have to remember that blood pressure reduction in hypertension is a very good surrogate for clinical outcomes. In different trials, you see that there is a reduction in the stroke risk that is almost a linear line between the reduction in risk and the reduction in blood pressure. In that particular cartoon, the diastolic blood pressure, and the same with the composite endpoint of cardiovascular mortality. And there is also this line that makes no difference between drugs, but the point is that the reduction of the blood pressure is the key point, the first point to consider when treating hypertension. And focusing on beta blockers, the guidelines recommend as class 1 indication for the use of beta blockers starting the treatment of hypertension in chronic coronary syndromes, in patients with ischemia, angina, incomplete revascularization, heart failure, acute coronary syndromes, atrial fibrillation, and other arrhythmias, in pregnancy, and in many other situations. So in hypertension, it's clear that beta blockers more than ever play an important role, and this role is the importance of beta blockers is more than ever recognized. If we move to a stable angina, different guidelines. This is the European Society of Cardiology guideline, published in 2024. Beta blockers are the first line recommendation to control ischemia and angina, along with calcium channel blockers. And the compelling indications for the beta blockers in stable angina is the presence of hypertension, angina, of course, or ischemia, heart failure, acute coronary syndromes, and arrhythmia. So in the treatment of ischemic angina, or in the treatment of ischemia, myocardial ischemia in general, with or without angina, beta blockers are still considered a first-line treatment for this condition. The same happens with heart failure. We have 20-year-old trials, including trials with bisoprolol, carvedilol, metoprolol, and nebivolol, that demonstrate a benefit in the outcomes of patients with heart failure and reduced ejection fraction. And this recommends in the guidelines, recommendation in different guidelines. Again, in this example, the European Society of Cardiology guidelines, beta blockers are the cornerstone of the treatment of heart failure with reduced ejection fraction, and in particular, if there is angina, arrhythmias, hypertension, or elevated heart rate, that's established indication for heart failure, not only with reduced ejection fraction, but with heart failure with preserved ejection fraction of mildly reduced ejection fraction. So in mildly preserved ejection fraction, a mildly reduced ejection fraction, beta blockers are considered a specific indication if with the heart failure, this angina, arrhythmias, hypertension, or tachycardia. If we move to arrhythmias, that is very difficult and interesting topic. Arrhythmias are still considered as class 1 for beta blockers in atrial fibrillation to control the heart rate, in ventricular tachycardia to improve the outcomes, in long QT syndrome to prevent ventricular arrhythmias, and in primary and secondary prevention of sudden cardiac death. In fact, beta blockers were the only drugs that consistently demonstrated a reduction in sudden death after myocardial infarction and in heart failure. You can see that in different trials. In these 6 different trials, there was a significant reduction of sudden cardiac death through the evolution of patients in these trials comparing beta blockers with placebo. This information may have become obsolete or not. We are going to discuss that. But even in patients with ICDs, beta blockers are related when in improving survival with a decrease in mortality. And from this data from the MADI-2 trial, you can see that patients with ICDs receiving beta blockers have a better survival than patients with also ICDs and not receiving beta blocker treatment. So still in the modern time with the use of ICDs, the use of beta blockers along with ICDs improves survival. In acute myocardial infarction, the recommendations are still are in acute myocardial infarction, in the acute setting, is the use of beta blockers if there are no contraindications and the blood pressure is above 120 millimeters of mercury, and preferably before starting the procedure for the PCI or thrombolytic treatment. And the recommendation is for continuing the beta blockers was still recommended to start as soon as possible with a beta blocker if there were no contraindications in the American Heart Association guidelines as well as in the European Society of Cardiology. But the problem is that we don't know if with modern therapies, beta blockers in patients with preserved ejection fraction play still a role for improving outcomes. And how long, if we use beta blockers after myocardial infarction, how long the treatment with beta blockers should be continued. So this is the important part of the presentation and the more interesting for discussion. The role of beta blockers long-term after acute myocardial infarction. That is in secondary prevention, where beta blockers were considered the king of treatment through the last 30 years. And we have several trials that were recently published that include the Reduce AMI, Reboot, Vitamin Sweetheart, ABIS, Capital RC, and there are a number of trials that are still ongoing, and all started early after myocardial infarction, but post-myocardial infarction, not during the acute phase. That is a different beast. You know, the first day of acute myocardial infarction is already, the beta blockers are still considered as already mentioned. So these trials produce a revolution in the way of thinking of for the use of beta blockers after acute myocardial infarction. And let me briefly review the trials, not in detail, but in the important message. The first one was the Capital Research Clinical Trial that was conducted in Japan some years ago, 5 or 10 years ago. The inclusion of the patient, it included a reduced, relatively low number of patients. Patients were STEMI patients that were treated with primary PCI as soon as they arrived to the hospital. Left ventricular ejection fraction should be over 40%. They were randomized to beta blocker or not, and the beta blocker they used were carvedilol. And the surprise, it was not really a surprise, it was the hypothesis that there was no differences in the composite point of death, myocardial infarction, stroke, admission for acute coronary syndromes of heart failure, or any coronary revascularization. So this was a neutral trial that was a surprise and started the organization of the other trials that were ongoing, but we already know the results. The VITAMI, the reduced sweetheart, the review on the ABIS. In the review that was mainly a Spanish trial, over 8,000 patients were included with acute myocardial infarction with or without ST segment elevation. So an increase in troponins was enough to consider patients as an acute myocardial infarction, of course. Patients should have a left ventricular ejection fraction of over 40. There was an open label study. The investigators could use any beta blocker and those, and there was somehow a significant crossover in the two groups over the evolution, and the event rate was lower than expected. Somehow, these are, some things that we have to consider, but the study was neutral, and it was 8,000 patients, a pragmatic trial with no difference at all in the composite of death, all-cause death, reinfarction, or heart failure of hospitalization. So that was a neutral trial that challenged the use of beta blockers in patients with acute myocardial infarction and a left ventricular ejection fraction over 40%, which is not normal, but it's over 40%. In the second trial, the VITAMI study, they included over 5,000 patients, again with acute myocardial infarction with and without ST segment elevation, with a left ventricular ejection fraction again of over 40%, but 50% of the patients had an ejection fraction between 40 and 50%. They could use any beta blockers, and those, although 90% of the cases, metoprolol was the beta blocker of choice. It was a very selected population, because in the screening, over 70% of the patients were excluded. And the results of this trial were slightly different from the previous one. There was a reduction, significant reduction, in the composite endpoint of death, myocardial infarction, revascularization, stroke, heart failure, malignant arrhythmias, in favor of the use of beta blockers through the trial. The next study is the reduced with heart, with 5,000 patients included in the trial. That was a registry base in patients with left ventricular ejection fraction over 50%, so normal left ventricular function. They were randomized to receive beta blockers or not. Most of the patients received metoprolol or bisoprolol, and there was not statistical differences for the composite of death from any cause or cause death, new myocardial infarction. That was the primary endpoint of this trial. So that was a neutral trial. And then we have the ABIS trial, that is a French trial, including over 4,000 patients with acute myocardial infarction of more than 6 months before. And these patients were stable for the last 6 months after the episode of acute myocardial infarction. They were included if they have a left ventricular ejection fraction over 40%, but again, 50% of the patients presented an ejection fraction that was between 40 and 50%. They could be treated with any beta blocker of those, and the study randomized the patients for the continuation of beta blockers after 6 months of receiving beta blockers after a myocardial infarction, or interruption of the beta blockers. And they found that there was a significant reduction. Well, there was not a significant difference for equality between the two groups, interruption and continuation. That means that there was a significant reduction in the composite endpoint of death, myocardial infarction, stroke, of hospitalization for cardiovascular cause. So that was a positive trial. So we have an amalgam of trials that were with good results, with improving outcomes, or with neutral results, and that is the beauty for the discussion. But if we compare what is happening with outcomes in registries, in more or less contemporary registries, certainly registries in a time where we use statins, we use a lot of revascularization, primary PCI, good antiaggregants, and so on, rehabilitation, and so on. So these modern therapies, they are in these registries, including a huge number of patients, the death rate, all-cause death, is 12% in the first year, 50% in the first year, 10% in the first year. That contrasts with the low mortality and the low number of events in the trials, recent trials that have just commented. REDUCE, REBOOT, BETAMI, and capital Japanese trial, you know. So the mortality and all other components of the outcomes are much more higher in the registries, in real life, in the real world practice, clinical practice, that's in this randomized clinical trial. It means that there is a selection bias that prevents us to say that beta blockers, we have evidence to say that beta blockers are to be abandoned with modern day therapies, because the patients that were selected for this trial are low risk patients, and in these patients maybe there is not such a need of using beta blockers, but only very low risk patients with a mortality rate as low as less than 1% per year. And it is interesting to have a look at the subgroups. That is from the ABIS trial. There was an interesting observation that there was a trial where there was a significant benefit in patients with hypertension that continue with the beta blockers as compared with patients with hypertension that discontinue the beta blockers after 6 months after an episode of myocardial infarction. And there is also very interesting information in post-infarction patients that were included in the mentioned trials, reviewed BETAMI, reduced HAMI, capital RCT, with an ejection fraction between 40 and 50%. That is an individual patient meta-analysis from these trials. And you see that there was a 25% reduction in the cumulative primary endpoint that was, for this meta-analysis, death, myocardial infarction, and heart failure. So at least in patients with hypertension and patients with mildly reduced ejection fraction, there was a benefit from beta blockers in contemporary times. So the bottom line here is that in secondary prevention, long-term treatment after acute myocardial infarction have some compelling indications. One is heart failure, left ventricular ejection fraction of less to 40%, hypertension, ischemia, tachycardia, and ventricular arrhythmias. And these comorbidities are very prevalent in patients in chronic coronary syndromes. For instance, in hypertension was around 80% in modern contemporary registries, and beta blockers were the choice of treatment for hypertension in these patients with chronic coronary syndromes. But the next question is, what is a beta blocker, and how can we select a beta blocker? And that is a difficult and long discussion, but you can see that beta blockers are drugs with a very different profiles. Some have intrinsic sympathetic or mimetic activity that should not be used. Some have other properties, different doses in different conditions. And my take is that beta blockers, beta 1 selective beta blockers with not intrinsic sympathetic mimetic activity are the best choice because they may improve insulin resistance, lipid profile, erectile dysfunction, have less secondary effects. And there is contemporary evidence with bisoprolol, metoprolol, and nebivolol, probably also with carvedilol, but that is carvedilol is not beta is considered as beta 1 selective beta blocker, but it is metoprolol, bisoprolol, and nebivolol the truly cardioselective of beta 1 receptors blockers. Moving to the contraindications of beta blockers, there are clear contraindications, that is symptomatic hypertension, hypotension, symptomatic bradycardia, complete AV block, and asthma. These are relative contraindications because hypotension can be controlled or maybe transient, same as bradycardia. You can use pacemakers. Asthma should be a true asthma, not just a bronchial reactivity. And there is a question mark on chronic obstructive bronchial disease, peripheral vascular diseases, diabetes, and erectile dysfunction. For instance, in chronic obstructive pulmonary disease, beta 1 selective beta blockers provide clinical benefit without bronchoconstriction, and there was benefit in large clinical trials. And there is a number of potential beneficial effects in beta blockers, beta 1 selective blockers, in chronic obstructive pulmonary disease, you can see here. In peripheral artery disease, also beta blockers, beta 1 blockers, are the best, the first line treatment for the control of high blood pressure, in peripheral artery disease with claudication, in acute coronary syndromes, and in chronic vascular diseases. That is a recent guideline recommendation from the European Society of Cardiology. In diabetes, you have to use beta blockers with caution because they may reduce symptoms of hypoglycemia, but that is not the case with beta 1 selective blockers. And in large clinical trials, the benefits of the use of beta blockers was the same in diabetics and not diabetics included in the trials. You can see in this particular trial that the use of beta 1 selective beta blockers as compared with non-selective beta blockers improves outcomes in the sense of lower incidence of new onset diabetes. And so the beta 1 selective beta blockers are the choice for the diabetic patients. Same for erectile dysfunctions. Erectile dysfunction may even improve with bisoprolol, and in particular with nebivolol. And in conclusion, beta blockers play a key role in contemporary cardiovascular disease treatment, are recommended in contemporary guidelines through the spectrum of cardiovascular diseases, and beta 1 blockers may be the best choice for efficacy and safety. And the bottom line, considering the new trials, is that the compelling indication of beta blockers is hypertension in cardiovascular disease, myocardial ischemia, heart failure, arrhythmias, atrial fibrillation, ventricular arrhythmias, tachycardia, and prevention of sudden cardiac death, and maybe not in patients without symptoms or these compelling indications after acute myocardial infarction, well treated during the acute phase of myocardial infarction. So thank you for your attention, and now we may discuss the topics that you may like. Thank you for your attention.
Thank you for this very great lecture. Now it's time to, I think let's have a discussion first. And for the panel, we have two doctors, and Dr. Jia Jun, just as I introduced, he's Deputy Chief Department of Cardiology, second affiliate hospital, Zhejiang University School of Medicine, and his interest is coronary artery disease imaging and physiology, optimized PCI in chip cases, and solutions for cardiac rupture and remodeling after acute myocardial infarction. And another discussant is Professor Yang Wenyi. He is from Shanghai General Hospital, Shanghai Jiaotong University School of Medicine. He's also the chair and chief doctor of the cardiology department of Shanghai General Hospital. And his specialty is diagnose and treatment of patients with coronary and structural heart disease, and focus on population and clinical studies on cardiovascular disease. I think let Dr. Jiang Jun, I think he's offline, and Dr. Yang Wenyi, would you please the first?
Yeah, okay. Thank you very much for the nice introduction, Professor Guo. And also, I feel very honored to have such a chance to follow your the lecture, Professor Lepo Sendem. I think you give a very nice, although summarized information, but very nice summarization of all of this information. But I'm so quite interested in the last four charts compare the beta block, whether beta blocker should be used for those with coronary artery disease, especially for those with myocardial infarction history. I think the main message, maybe if you look at the conclusion of these trials, I think they are quite controversial to each other. But if you look at the details, I think they are not telling us this, the different stories. For instance, the beta blocker is not the same always in the different trials. For instance, for the my memory is still sharp, I think maybe for the beta AMI's trial, as a majority, 95% of the beta blocker was metoprolol. And then if you go to the best trial, I think 71 are metoprolol. I think they are quite different from each other. Maybe that's one of the drivers of the difference between these trials. And on the other hand, the ejection fraction values, although they are saying they include the patients with ejection fraction greater than 40%, but at the end, what the reality of the ejection fraction distribution among these patients, I think is still quite different from each other. According to me, I think maybe for the beta AMI trials, I think majority of them had the left ejection fraction greater than 50%. But I'm not sure how about the obese trial and some other trials. If they have totally normal ejection fraction value, I think they are not really likely to have the beneficial effect from the beta block treatment. But on the other hand, if you have the ejection fraction value between 40 to 50%, probably you will still have some beneficial effect from the beta block treatments. But of course, I think beta blockers are still, as what you mentioned, very needed in the field. Even I think ESA's trial, I think Professor Gao maybe will come later with his points. Beta block still needed. Even European guidelines, including European ESH guideline and ESC guideline, there are not too much difference between these two guidelines. But then, according to when it comes to the point whether beta block should be used or not for antihypertensive treatments, I think they are quite have the same agreement that beta blocker should be. Yeah, they changed from the previous guidelines. They are both included beta blocker as the first line treatment as antihypertensive medications in several different cases, and also for some specific for those patients with heart failure, especially reduced ejection fraction heart failure, and also had the relative high heartbeat. I think they should be used at the first line. And also for those patients with relatively young age, and they had relatively high diastolic blood pressure instead compared with the systolic blood pressure. I think for those patients, we are still commonly used the beta blocker as a first-line treatment to control the isolated diastolic hypertensive patients. But then I still have a concern to ask Professor Lepel-Sutton, and how do you thinking about we to have a trial to compare, because we don't have a trial to compare beta blocker treatments for those with isolated diastolic hypertension patients, whether they can have the benefit from the antihypertensive treatments or not. But of course, that could be difficult because those patients are relatively young. We need relatively long time follow-up to have the events, and they are relatively have a low risk. Probably the sample size should be also very large. But anyway, do you have some comments on that? Whether we need a trial to compare, whether we need a treatment for those patients with isolated diastolic hypertension, and what kind of medication will be the first line or first choice? And what's your opinion, especially for your daily practice, Professor?
Well, that is a very good question, and I think that high blood pressure, one of the modern concepts of blood pressure is that is in the definition of blood pressure, and the levels of definition that are different guidelines. And so the modern concept is that there is a continuum on a risk from very low blood pressure, extremely normal blood pressure, and very high blood pressure. So there is not a cutoff point. So if a young person, in particular a young person, have a diastolic blood pressure that is considered as high, let's say 90 millimeters of mercury, and is not controlled with lifestyle changes, diet with less salt, and so I think it's a good candidate for start a beta blocker treatment, because there is not a cutoff point. There is a line of for increasing risk or decreasing risk for the blood pressure, and certainly a trial in this population will be extremely difficult, because because especially in young population, the number of events is huge if you consider the number of people with hypertension, but otherwise in the selected population for a trial, you will need thousands of hundreds of thousands of patients included in the trial, and that will be impossible, But my take is that I think these patients should be considered for taking some action, diets, lifestyle, and if that doesn't normalize the blood pressure, the diastolic blood pressure, I think there are candidates for treatment, beta blockers or whatever.
Thank you.
And the other comments you made, I agree with your comments on the recent beta blocker trials. There is an amalgam of things. There are trials that are what we call nowadays pragmatic trials. That is, I can do whatever I please, But somehow is something in between a well-controlled randomized clinical trial and a registry with selected patients according to the profile of the patients. But certainly there is something that can be is not really a conclusion for the trials, but it's something that in clinical practice you question yourself more and more often than not. And this is the patient that comes to the hospital with an episode of an acute myocardial infarction and goes through the cath lab, There is a single lesion, no other lesions to revascularize. The primary PCI was effective, and the patient changes his way of life. Stop smoking, starts doing some exercise, is taking aspirin, the diet improved, is taking something for cholesterol, and is asymptomatic. So the mortality of these patients, of the probability, the risk of these patients for a new event is extremely low. And I don't see the reason for having a patient with taking several medications at the same time, and so probably in this case, it's a beta blocker after a few weeks or even after discharge from the hospital. If there is no hypertension, heart failure, arrhythmias, myocardial ischemia, residual coronary stenosis, and so on, I think a beta blocker, there is no way a beta blocker can reduce what is not going to happen anyway. So there are selected patients in clinical practice where common sense is supported by these controversial results in a huge population of patients.
Okay, thank you. Thank you very much.
Thank you.
It's a goal.
And also we have Dr. Jiang Jun here. Do you have any comments?
Okay, thank you, Dr. Guo. It's a really very, very nice lecture. I just have one short question. Regarding some recent evidence for beta blocker in patients with acute myocardial infarction, what's your, the recommendation for what kind of patients should receive? Should some patient, is there a possibility that stops the beta blocker during the long-term follow-up, especially in patients with a preserved ejection fraction?
Well, I think that in the setting of acute myocardial infarction, that means, and the setting of acute myocardial infarction nowadays is the 21st hours of the episode after the start of chest pain for the episode of myocardial infarction. In these cases, there is still the recommendation of the use of beta blockers, including intravenous beta blockers, and in particular, if for whatever the reason a primary PCI was ineffective, you could not open the artery, or there are residual coronary stenosis that you cannot solve with PCI or surgery. In that cases, beta blockers should be started from the very first time, the very first hour of acute myocardial infarction, and the discontinuation depends on the information we have now is that the beta blocker therapy should continue at least for 6 months, and then if there is no heart failure, myocardial ischemia, angina, hypertension, arrhythmias, or anything, everything is going fine, cholesterol has been controlled, the patient went through a rehabilitation process, and is improved the lifestyle. Again, there is when you in that case you can discontinue the beta blockers. Also, more than for common sense, that for the results of the French trial.
Okay, thank you.
Someone mentioned heart rupture after myocardial infarction, and as one of your preferred topics, and it happens that beta blockers in the old days reduce heart rupture in acute myocardial infarction. Before revascularization area and thrombolytic area, heart rate was probably the main cause after a cardiogenic shock for mortality after myocardial infarction. And beta blocker reduce of the incidence of early beta blocker use from arrival to the hospital, reduce the prevalence of or the incidence of heart rupture after myocardial in the acute setting of myocardial infarction. So if there is no opportunity for primary PCI, or thrombolytic treatment immediately after the diagnosis of myocardial infarction, especially myocardial infarction with ST segment elevation, beta blockers should be used. It's a good choice, can be used almost anywhere, along with aspirin, and it improves outcomes and reduces the prevalence or the incidence of heart rupture.
Okay, thank you. May I have a small quick question, and maybe without any, evidence currently. Beta blocker is a very important drug for hypertension, especially for the patients with a very increased activity of sympathetic nerve. But now we have RDN for the new treatment of hypertension patient. Do you think after RDN surgery, beta blocker is still very important for those kind of patients?
Well, I think that things change and we have new medications, but for the particular patient you are talking about is a patient that with a lot of sympathetic activity, no?
Yeah.
And I think that in these patients still beta blockers are fine to be used. We are one of the important things with using modern therapies is your experience, how to select the patients, how to increase the dose, how to decrease the dose, how to combine one particular drug with another, and that is something that you have to do in hypertension all the time. In the summertime, you have to decrease vasodilating drugs and so on. You are changing the treatment all the time, And in patients with high sympathetic activity, I still prefer beta blockers. As an anecdote, years ago, so you don't know the name of the person I'm talking about, I was the physician of one of the presidents of Spain, and he had hypertension, nothing but hypertension. And so I decided, well, that you're the perfect case for using beta blockers because your stress through the day should be incredible, and with the discussions in the department and so on. And his wife, that was in the same room with both of us, said, well, this man doesn't care for anything. He's never nervous. He doesn't care. The heart rate never goes up, even if he's discussing with anatomy or something like that. But if that is an anecdote, but if there is truly a concern with the sympathetic nervous activity, I still think beta blockers are a good choice for the treatments. It makes sense.
Yeah, okay.
Good
Thank
point.
you. Yeah, thank you. And thank you for the wonderful lecture again. And because of the schedule, we will move to the next speaker. Thank you. And
Thank you.
yeah. Next speaker is Professor Gaodong Feng, and he is the chief physician and supervisor doctor in second affiliate hospital of Xi'an Jiaotong University. And as you can see, he has a lot of membership in a lot of society in China, and he studied at Washington University in St. Louis, USA. And please, Dr. Gao, you can start your lecture.
Okay. Thank you for the introduction from the Professor Guo, and I will share my slides here. Oh, is that okay?
Yeah, go ahead.
Okay. Dear professors and colleagues, it's very great honor for me to attend this seminar on beta blocker today. We know that beta blocker today remains the most debated classic drugs in cardiology. But in this year, and in last year, 2025, there have been a lot of late clinical trials on this area. And now I will share some new clinical trial data with you and some changes in the latest evidence of the beta blocker mainly used in after myocardial infarction. And for my presentation here, I will cover in two topic. First, we will structure today's first. We will examine the new recommendation for the beta blocker in the 2025 ESC guideline. The second line, we will divide into three major clinical trials published in 2025 that are reshaping our understanding for the beta blocker, most in post-myocardial infarction patient care. And so let's start with the newly changed guideline first. You can see in this slide that for the valvular heart disease guideline, which published in 2025 ESC, there are some mentioned about beta blockers. We can see here in the aortic regurgitation, we all know that beta blocker prolong the diastolic period, which can physiologically increase the regurgitation volume. Therefore, for this patient, we should use beta blocker with caution. However, for the patient which may have systolic heart failure or persistent tachycardia, a beta blocker can be used post-operationally. It is typically in combination with such drugs as ACEI or ARBs. This reflects a shift toward more individualized therapy based on overall cardiovascular profile rather than just the disease such as valvular disease alone. For the secondary mitral regurgitation, we all know for the mitral regurgitation, the first thing we should do is to emphasize the GDMT therapy for this patient. If we do GDMT, the heart may be smaller. And so for this patient, before the valvular intervention, we should do GDMT first. This includes also the GDMT include the beta blocker, and also we all know the SGLT2 inhibitor or ACEI-ARB, other such drugs. In case of non-structural valvular dysfunction, such as perivalvular leak with significant hemolysis, beta blocker are mentioned as potential option to reduce hemolysis, possibly by lowering shear stress. This is what we can see in the valvular heart disease guideline that mentioned the beta blocker in the newly guidelines. And for the turning to the myocarditis and pericarditis guidelines in 2025 ESC guidelines, we can see that the beta blocker was classic 2 recommendation in two specific scenarios. First, in pericarditis patient who remains symptomatic despite anti-inflammation therapy and who have the resting heart rate above 75. In this patient, the beta blocker can be added for better symptom control. And secondly, in acute myocarditis, especially with elevated troponin or arrhythmia, beta blocker are recommended for at least 6 months to manage arrhythmia on or potentially lower the myocardial inflammation and reverse the remodeling. This is a structured, time-bounded approach to a condition where treatment was previously less defined in this kind of patients. And for some in specific patient, the new guideline told us more about beta blocker. For cardiovascular disease patient who was pregnant, the guideline told us some details. For pregnancy, the beta blocker are strongly recommended in women with Marfan syndrome or other aortic disorders throughout pregnancy and postpartum to reduce aortic stress. In long QT syndrome, not Adderall or Propranolol are preferred. with dose adjusted to pregnancy levels and continue during the breastfeeding. And for the mental health, in the newly ESC guidelines, it is mentioned that some of the beta blocker with the hydrophilics do not cross the blood-brain barrier. So this kind of drug may not increase the depression risk. So this drug is maybe safer to use a patient with or at risk of depression. So this gave us the evidence to treat the patient with this kind of risk. And after we share the newly published guideline, and we can move to the newly latest clinical trial about a beta blocker, mainly about the patient after myocardial infarction. Just mention for the professor. The first clinical trial I want to present here is beta-amine dam block study. This study was published in New England Journal of Medicine in August 2025. This was a large open-label randomized trials conducted across 44 centers in Denmark and Norway, and it enrolled about 5,574 patients within 40 days after myocardial infarction, all with a left ventricular ejection fraction of above 40 or higher, which means that these patients all have preserved or mildly reduced in heart function. The key question for this trial was, does a long-term beta blocker therapy benefit patients after myocardial infarction if their heart pump function is relatively good for the patient with relatively good heart failure, whether heart function, whether the beta blocker may have the benefit. And this has been a gray area in cardiology for these patients for many years. Patients were randomized to 1-to-1 to receive beta blocker therapy or no beta blocker therapy. The primary endpoint was a composite of all-cause death mortality or the major adverse cardiovascular events, including recurrent myocardial infarction, unplanned revascularization, or ischemic stroke heart failure, or malignant ventricular arrhythmia. And they wrote about the patient and follow about familiar about 3.5 years, which a robust following up period. And we can see in this slide the baseline characteristic of the patient are comparable in two groups. And for the primary result here, we can clearly show that the cumulative incidence curve for the primary endpoint events begins to separate early and continues to widen over time. And long-term beta blocker therapy significantly reduces the risk of the composite endpoint compared to the non-beta blocker therapy. For the secondary endpoint results, we can see in this slide, the bar chart on this slide show a lower incidence rate in the beta blocker group for all cause deaths, recurrent myocardial infarction, hospitalization for heart failure, and malignant ventricular arrhythmias. This tells us that the benefit is not driven just one type of the event, but across all the spectrum of serious complications after myocardial infarction, which reinforce the cardiovascular protective effect of the beta blocker after myocardial infarction. And it is very interesting for the subgroup analysis we can show here. And the first plot here is very informative. It shows that the treatment effect across different patient subgroups. And we can see in some subgroup, we can see a profound benefit in this kind of group. And you can see in those patients with the LVEF between 14 and 49, and the patient with STEMI, and the patient with of the woman, and the patient with diabetes, it may have profound benefit in this kind of subgroup. This suggests that maybe after myocardial infarction, within the broader population of the post-myocardial infarction patient, we can define those who stand to gain the most absolute benefit from the therapy. So there may be some subgroup difference between this kind of group. And after we introduce beta me trial, we move to another very interesting study here. This trial is just an individual patient data analysis. It pulled the data, individual data from 4 randomized trials, Reboot, and Betami, and Dan Block and Capital, and focusing especially on the post-myocardial infarctions with mildly reduced ejection fraction. The ejection fraction of this patient is 40 to 49. And of course, this patient have no prior heart failure. And this meta-analysis gives us a more precise look at this important subgroup. And we can see in this slide that in the 2 subgroups, about 40% of patients have STEMI, reflecting a higher risk of cohort of this meta-analysis. And we also can see in this kind of patient, Bisolol was given to about 44% of the patient, which was very common in our daily use. And the patient were randomized within the 40 days of myocardial infarction and follow for about years. For this individual data analysis, we can see the primary finding in this slide. And we can see the KM curve on the left clear show a significant reduction in the cumulative incidence of the primary compositive endpoint, which include all-cause deaths, new myocardial infarction, or heart failure in a beta blocker group versus the control group. The hazard ratio is about 0.75, consistent with the findings that we presented just now from the beta-MI findings, confirming that even in this borderline EF group, beta blocker maybe have some meaningful protection effect for this with patient with mild and reduced heart failure heart function. And for the secondary endpoint analysis, we can see here, for the individual component, we can see the beta blocker may have some effect on the cardiovascular death, new myocardial infarction, heart failure, and with the treatment of the beta blocker, we can see a reduction of this kind of event rate. The consistent indirection of this effect across all endpoints strengthen this conclusion of the beta blocker, which was used in the patient with mild heart function. The very interesting is shown in this subgroup analysis. The fascinating finding from this meta-analysis come from this slide, and we can see the dose analysis here for the subgroup first plot. We can see here the medium or low dose of beta blocker were associated with the greatest clinical benefit, whereas the higher than medium dose group did not show a significant advantage over control. This implies that some is good, more is not necessarily better. So for this kind of patient, maybe we should add a little beta blocker to this kind of patient, but we don't need to push the dose to a relative high level because it was not benefit for this kind of patient. And after this meta-analysis, let's move to another question: whether the patient after myocardial infarction with the higher heart rate, if we use beta blocker to lower the heart rate, and if we stop this beta blocker, whether it will change the outcome of this patient. The IBAS study tell us more about this area, and we can see here the question of the IBAS study is it safe or to stop the beta blocker in the stable post-myocardial patient? So this answer the question, how long we should use the beta blocker after the myocardial infarction patient. And this is a French multi-center trial and randomized over 3,400 patients with EF above 40% to either interpret or to continue beta blocker after at least 6 months of therapy. As shown in this bar, we can see here the primary endpoint instance was a little difference between two groups. And the intervention group had a higher incidence rate, but the continued group had a lower incidence rate. And the interventions strategy have increased in hospitalization for cardiovascular cause, particularly in the coronary-related cause and angina and ischemic. So it is clear from this study we can see here that do not stop beta blocker routinely in we usually think the stable patient after the post-myocardial infarction. Maybe we should prolong the use of the beta blocker for this patient. And the very interesting is that if we divide this patient by their baseline heart rate, and we divide this patient to three group of the based on their resting heart rate, and we can see the lower group, the middle group, and the higher group. The goal was to see if the baseline heart rate influence the risk of the stop therapy, and this is very interesting. We can see here, and the finding are striking. The graphic here show that a patient with higher baseline heart rate had a significant increased risk of the secondary endpoint. It is said that if the patient had a higher heart rate, maybe you early stop the beta blocker treatment, maybe he have a higher risk for this kind of patient. So it is clear to see that the dose response relationship was also so here, and maybe so in our clinical practice, if we have a patient after myocardial infarction and the baseline heart rate is very high, so for this patient, we should use a beta blocker for a longer time, and we should not stop it earlier, maybe for this kind of patient. And we can also see here that the discontinue of the beta blocker lead to a markedly bounced increase in heart rate. And for the patient with higher heart rate, the rebound is very severe. And so this slide tell us maybe the worst outcome for the intervention group, maybe because of the now control of the heart rate for this kind of patient. And for the other spectrum, we can see that we now know that beta blocker may be used for the treatment of the hypertension patient. So this slide highlights another critical intervention in patient with hypertension. Intervention of the beta blocker therapy leads to increase of 27 increased risk of primary composite endpoint, which was statistically significant. But in non-hypertension patients, there was a trend, but it was not significant. This suggests that if the patient with hypertension, for this, especially for the higher sympathetic tone, and we might be continue use of beta blocker for a long time, because if you withdraw the beta blocker earlier, it may have some bad effect for this patient. So let's synthesize these three key studies. BETA-MI confirmed that starting beta blocker after myocardial infarction might be benefits for the patient with the preserved EF value, especially patients with EF above 40 to 49. individual data analysis to refine this finding, showing clear benefit in the patient that with the EF between 40 and 49 group might have clinical benefit, possibly for the moderate dose, but not for the higher dose patient. For the IBAS study, it provides the critical caution tells that which tells us stopping the beta blocker might lead to a heart rate rebound. And for the patient with baseline heart rate of higher level, or especially in hypertension patient, it may have high risk for this kind of patient. Taking this finding together, we know that after the myocardial infarction, even in a patient with good heart function or mild damaged heart function, starting beta blocker may be early, and we might continue them for the longer time, especially in the patient with the higher heart rate and in patient with hypertension. And these four trials are rapidly being incorporated into the guideline. We can see that in 2025 AACC guidelines that are now recommended in initial about within the 24 hours for oral beta blocker in ACS patients without contraindications as a class 1 recommendation. We can see here the recommendation of the ACC guideline. And for the Chinese guideline, the similar recognition of the beta blocker as a first-line anti-ischemic therapy after PCI was also shown here. And for longer-term management in this patient with reduced EF after the post-myocardial infarction also was recommended. But after we show there are a lot of evidence from the patient with myocardial infarction after the myocardial infarction with the mild heart function, we can see that even in this patient, maybe with EF of 40 or 49, maybe this kind of patient may have benefit, especially in patients with the baseline heart rate of higher level, and for the patient with hypertension patient maybe have more benefit in this kind of patient. For the summary of the topic today we gave here, and beyond the coronary heart disease, the 2025 ESC guideline solidify the beta blocker role across cardiology. They are recommended in valvular heart disease, myocarditis, pericarditis, and cardiovascular disease in pregnancy patients, and are noted as not increasing depression risk in the mental health concerns. And this broad endorsement underscore their fundamental roles as very useful tools for treating of the cardiovascular disease. So what should we do on Monday morning first for the post-myocardial infarction patient? Even with left ventricular ejection fraction above 40, initial and continued beta blocker for a longer time may be considered for this patient, especially in patients with the baseline heart rate of a higher level and with the hypertension. And secondly, we should think twice or three times before we stopping a beta blocker in a stable post-myocardial infarction, particularly in this patient have hypertension or higher heart rate. And thirdly, use of beta blocker confidently in the new scenarios outlined in the ESC guidelines from the myocarditis to pregnancy patient. Armed with this updated evidence, we can use beta blocker in all the new area of this kind of patient. So beta blocker still remain a very useful tools for our clinical specialists to treat the cardiovascular disease. That's what I share here. Thank you for the presentation here.
Thank you for Professor Gao shared us with the latest guidelines about beta blocker and latest clinical trials. And I think we still have 10 minutes to discuss together. And Dr. Jules, do you have any comments about this topic?
Well, it was a nice and detailed review of the recent recommendations in the guidelines. That is really difficult to gather, because you have to go through all the details in guidelines that apparently have no relationship with beta blockers, but beta blockers are included there, and so I enjoy the presentation, and I think that it reinforces the concept that beta blockers are still here for a good use in clinical practice. And these recent trials just raise a question that will be in the discussion on many forums, and that is good for taking decisions and for considering beta blockers in a number of situations that maybe were forgotten for many people now. So thank you for the presentation. Yes, enjoy it.
Okay, thank you. And Professor Jiang Jun, any comments?
I think it's a very good talk. Give us a very good review of the recent role of beta blocker in patients with cardiovascular disease. Even there are still some maybe discussions or questions about its effect, but we know beta blocker is still a very important treatment especially for patients with heart failure, with tachyarrhythmia, and so on. So we should consider to use especially the beta blocker with good evidence, such as bisoprolol, metoprolol, and carvedilol. Thank you.
Thank you. And Dr. Yang?
Yeah, thank you, Professor Guo, and thank you for Professor Gao give us very nice summary of the recommendations and also the evidence from the recent trials and the guidelines. And I fully agree with the comments that Professor Jiang and Professor Lapet-Sadun had mentioned. According to me, I think we still need to go to the details to compare. There are several trials. They are not really although the results or the conclusion are somehow controversial to each other, but we need to be careful to say that, especially to treat our patients. I think these trials are not really have the similar design. They are not included the similar patients. Even the ejection fraction might different from each other. As Professor Gao had mentioned, the individual patient level meta-analysis already show that for those patients with ejection fraction in the range of 40 to 49, they still have the beneficial effect from the beta block treatments. That also tells us that actually ejection fraction might be a very important indicator to thinking about which patient need to be treated or not with beta block or not. And that's one of the things I think really catch the eyes of the experts in the field concerning beta blocker in the myocardial infarction patients. Actually, I think there is also another different opinions or controversial or argument in whether beta blocker should be treated as a first-line antihypertensive medication. As what I mentioned just a few moments ago, the ESC and ESH guideline, although they have some difference from each other, but they made the similar changes from the previous version of the guideline. They now agree with that this beta blocker should be treated as the first line antihypertensive medication classes. I think that almost all of the Chinese physicians, especially the experts in the field, are quite agree with that, because we had never dismissed this beta blocker as the first line antihypertensive medication. And of course, as what I mentioned, we still need to dig into and do some more research to figure out which class of patients or which group of patient will have bigger or greater beneficial effect from the beta block treatments. So far, I think all of the maybe experts agree that we might also use the heart rate as an indicator. Whether the patient has relatively high heart rate, probably we need to thinking about with beta block treatment. But I think I would like to point out we also need to be very careful because from the observational study that we found heart rate is a good risk factor to predict the long-term events or risk of the patients. But we also need to think about this might not really because of the heart rate itself. It might be the underlying sympathetic tension of these patients. So what we treated is not really the heart rate itself. It's because of sympathetic control. If we agree with that, we need to thinking about some other medication. They can maybe, for instance, some CCB can help us to control the heart rate, but they might not mimic the benefit effect of a beta blocker because the CCB sometimes will control the heart rate but increase the sympathetic tone. But that's also one of the points that I would like to mention. But I'm not sure whether Professor Jiang Gao and Professor Leopold or Professor Guo, you have some comments on that or not. Thank you. Thank you, Professor Gao, for a nice talk.
Yeah, thank you. I totally agree with you. I think there is a gap between the hypertension treatment about beta blockers in China and in European countries. In most of us, we use RNA CCP as a first line, as not instead of a beta blocker. So there's a gap, I think so.
Yeah,
So,
and I concur that probably one of the most important news or recommendations comes from the European Society of Hypertension, focusing on the fact that the priority in hypertension is reducing blood pressure. And then you have to go through the profile of the patient with the comorbidities to select the preferred choice of drug, and beta blockers that were always, during the last 20 years, were relegated to a second step or a third step, become probably one of the most useful therapies for the treatment of hypertension, and that is probably the more relevant change in the recommendation of guidelines. And the second thing is that the heart rate, the heart rate is a marker and it's a risk factor. It's a marker that means that a tachycardia, 100 beats per minute or 90 beats per minute, should consider as something wrong is happening, and that is sympathetic activation. And it is not only treating the tachycardia, is trying to find why there was the heart rate so high. That is one thing. And yes, in many circumstances, is useful to tailor the dose of the beta blockers. The heart rate control. Yeah.
May I have one more? May I have one more question?
Yeah.
To Professor Leopold, but it's not related to the topic that we are talking about today, but more maybe it's a sensitive question. You can, if you agree, you don't need to answer it. So there is two guidelines in Europe. I mean, the hypertension guideline. What are you doing now? Which guideline you are following, and whether there is some controversial or conflicts between these two? For the daily life. Yeah, what for the daily practice?
Fantastic question. We have too many guidelines for everything, but in particular for hypertension, because they not only have guidelines in every society, cardiology society, hypertension society, whatever, in different countries, in China, in Europe, in Spain, in France, and so on. But also they update the guidelines every 2 years or something like that, you know. And I used, some years ago, I used to have 3 questions for the students that in medical school, that the students should give the right answer, or they could not be qualified to become a physician, you know. And one of them was to know if a person was dead or alive. That is simple, you know. If you don't know that, you're not qualified to be a physician. But the second one was the normal levels, the normal figures, the normal numbers for blood pressure. And I consider that a very important question, because for every physician, they should know how to recognize a patient with hypertension to be treated, you know. But I abandoned this question after some years, because the normal blood pressure was changing all the time. So my bottom line here is that you have to go to your local guidelines that are the guidelines that will reflect more closely what is happening around you, what medications are available in your country, and what comorbidities are available in your country, and so on. No? The second bottom line here is that my preferred choice is the last European Society of Hypertension guidelines rather than any other, because of this concept that the key point is reducing blood pressure to a level that may be different in different persons, you know. In a younger person, 120 over 80 could be the target. But in an elderly person with long-standing hypertension, especially a quick reduction of blood pressure could have very important secondary effects, including dementia, or not dementia, but disorientation. The patient go for a walk and get lost in the street and something like that. So there are some people that need to tailor therapy for a particular level of blood pressure according to their needs, you know. But the concept is that blood pressure is not to discuss the treatment, is to reduce blood pressure with either ACE inhibitors, beta blockers, diuretics, or calcium channel blockers. And I think beta blockers have the priority because of the comorbidities that are compelling indications for the use of beta blockers.
Yeah.
Very good question, you know. And the answer is too many guidelines, you know. So when you have too many of something, you choose what you please, and that is it.
I hope that the physicians make the treatment plan not based on the friendship, mainly based on the evidence, because I think there are 2 groups of people. They are supporting the ESC guideline. There are another for people supporting the ESC. But I think majority of the recommendation are quite similar to each other, and the bottom line that you mentioned are also similar, described in both guidelines. I think yes.
Yeah. Thank you.
Thank you.
Thank you. Thank you, all the doctors, and I think it's time for the close session, and especially for Dr. Jones. Hopefully, we will have chance to discuss face to face, and welcome to China in the future.
Okay.
Thank you.
Thank you. Thank
Looking
you.
forward.
Thank you, everyone.
Good
Thank
night.
you. Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Enjoy the rest of the day.
You too.
Bye.
Rest of the night. Bye-bye.